So now is the time for a panel discussion. So I invite here up front our residents. Our group from University of Minnesota is led by Meghan Lindstrom, who was our resident and now she's the fellow in Hempat. And the group from Mayo Clinic is led by Jim Fleming, who was doing an observership with us previously, and now he's a resident over there. So please welcome them.
Thank you so much, Dr. Rotilla. And all of our panelists, please feel free to come up, get settled. Before we start, I just kind of wanted to give a little bit of a preface to this session. So over the last year or so, Dr. Fleming and I have been having a lot of conversations about trainee initiatives and increasing trainee representation and participation in activities through the Minnesota Society of Pathologists. And through the course of those discussions, we often find ourselves comparing and contrasting our programs, opportunities for trainees, what we like about our programs, what opportunities we see for improvement in our programs. And so we were really excited when Dr. Chen and Dr. Rotilla offered us the opportunity to put together a trainee talk, which turned into a trainee panel to discuss current pathology education at both of our programs, what our trainees really like about our programs, and identifying potential gaps and possible solutions to address those needs in our education. And so from a personal perspective, for those who have worked with me and know me, you know that I'm very passionate about education and improving educational experiences. And during my year as chief resident, I'm sure my fellow trainees grew very tired of me saying things like, you know, if you think our program is good, that's good. If you think our program is great, that's great. But if we don't think about ways that we can constantly improve our program, things can stagnate, and nobody really wants that. And so I'm really excited to hear what our trainees have to say about ways that they think our program can grow and expand to help them become the most effective and competent and well-prepared future pathologists that they can be. And I'm very excited as well to be able to hear from our colleagues at Mayo as well, so that we can all kind of learn a little bit more about where we are in pathology education and where we'd like to go.
I think that was very eloquently put, Meghan. This is a really special opportunity, especially in the context of a lot of the topics that have been brought up today regarding education. It's a good opportunity to hear different perspectives about how education has been for these residents. And I also wanted to pose this as an opportunity for everyone in the audience to please feel free to pipe in your experience as the panelists are reflecting on their experience. If it brings up a thought about an experience that you had that may relate back to the topic, that'd be awesome. So open engagement is highly encouraged. And one other thing I wanted to mention has to do with when I was visiting University of Minnesota as a medical student. It has to do with just the teaching environment in pathology. It's very unique, and it's something that Dr. Khalifa formalized. He likened the teaching environment in pathology to be somewhat similar to like sitting underneath a tree and looking up at all the stars in the universe above you and talking about things the way they are. And I feel like it's a special way to conceptualize the teaching environment. It's something that's core to the passing along of teaching. So yeah, with that in mind, we can get started. Perhaps the panelists could just introduce themselves, saying their name and their year.
Hello, everyone. My name is Yi Zhu. I'm from Mayo Clinic. I'm a third year. I'm AP-MP, so I'm doing AP 2 years and then neuropath. So technically, I'm a neuro fellow now. I don't have any CP training. So if you guys have any CP questions, I'm happy to answer.
My name is Chuan Chen. I'm also one of the third-year APCP resident from Mayo Clinic. Thank you very much for the meeting organizers for having us here to exchange our training experience, to know each other and learn from each other. Yeah.
Hi, everyone. I'm Sadia Nazli. I'm also a third-year APCP resident at Mayo Clinic, Rochester. Really excited to dive into the interactive discussion today, and thank you for having us here.
My name is Subramaniam Ramkumar. You can call me Ram. I'm a fellow in surgical pathology from University of Minnesota. So thank you for the opportunity to speak today, and I'm very happy to be here. And I did my residency, pathology residency in India, following which I'm pursuing a fellowship here. So I'll be very happy to take any questions on a international fellow level. Thank you.
Hi, everyone. I'm Asha. I'm a PGY3 and I'm an APCP resident. I've seen all the CP, mostly all of the CP in our training program. So if you have any questions about that, I'll be happy to answer. And also I'm doing AP, so I have a lot of insights into that as well.
Hi, I'm Marissa Wold. I am a second year APCP resident at the U of M. I have had somewhat limited exposure to CP as of yet, so I will defer to Asha.
Well, thank you so much to our panelists again for volunteering their time and their expertise. We really appreciate the opportunity to hear from you firsthand with respect to what you think of our programs and what you would like to see more of. So we do have a list of questions that we've prepared to ask our panelists. But again, if there's anything that you would really like to hear from our trainees, please feel free to raise your hand, flag us down, and we'd love to hear your questions and have our panelists have the opportunity to answer them. Yes. It might be the mic. I apologize. It seems like they're working, but they might be quiet. So yes, please.
Can you hear us now? Is that good enough?
Okay. How about now? Okay.
Okay. So while we're working with the microphones, first question that we want to ask our panelists, and it's very topical with respect to what Dr. Rendy covered today in her lecture, and it has to do with preparedness for residency. So as we all know, especially after Dr. Rendy's wonderful talk, pathology education, especially in undergraduate medical education, is changing significantly, and trainees are coming to residency with various levels of exposure and experiences in pathology. And so one of the questions that we want to hear from you is, when you started pathology residency, how did your programs provide foundational information to you? And did you feel, when you started your residency journey, did you feel prepared with respect to starting pathology analyses, looking at cases? And is there anything that you think that your program could provide to you, or additional educational opportunities that the program could help you with to make you feel more prepared to start residency?
I can talk about this a little bit. So I know at my medical school, as many across the country, has reduced the amount of exposure to pathology. Someone was talking about having a histology lab, and I had that in grad school, but I didn't really encounter that in med school, an interactive histology lab. So I think that medical schools in general are not doing an adequate job of exposing us to pathology and preparing us to begin our journey here. One thing that I do really like that our program does is we have a boot camp month in July. That was very helpful in getting initial exposure to the AP side of things. I have thought for a while that it would be nice to have something similar for CP, but the sort of breadth of the that side of things is would make it really challenging, I think, to have a like a CP oriented intro month. So kind of my pet project that I've roped a couple of friends into now is I've been creating these documents for every rotation. I call it the Welcome To series. It's just sort of all of the information that I wanted to know when I started the rotation that would be useful for future people to know. So, you know, what are some of the diagnoses that you're going to encounter on this rotation? Who are your main contacts? What are your responsibilities? We've also included links to conferences and whatnot. So hoping to continue that in the future.
I can talk about my experience from my perspective. I'm an international applicant. I did my medical school in China, and after that, I had years of research experience in the United States. So before residency, I'm away from medical school and from pathology for quite a while. So I think Mayo Clinic has done a very nice job in preparing me for the start of residency, at least in two layers. I think for the medical knowledge part, we have a very structured histology course organized by a senior resident before the residency started, so like a peer-to-peer learning teaching experience, which is a great preparedness for me. And also for the grossing, one challenge I encountered as an international applicant is resident is that some of the pathology descriptors are quite challenging for me in the beginning. For example, like as simple as the cut surface is solid versus cystic, or the color is mahogany, something like that. So those things, I think I would love to have like more exposure to grossing opportunities in the beginning of my residency. We also shared this feedback to the program. I think the program made further improvement for the new PGY1. I think starting from James here, we have adding in a core grossing month for like training the resident paired with one-to-one with a PA trainer for purely grossing for 1 month. I would love to hear James' experience on that, but I think that's another thing that the program prepare us for the start of the residency. Another thing, following our Minnesota colleagues on the CP part, I think we also have another layer of preparedness, like non-medical knowledge based. Things like how to use a pager, answering a CP call, yeah, and how to navigate myself in the subway, like a maze, like tunnels underground in the Mayo Clinic. So those things, like the tour to the frozen lab, the tour to the autopsy room. So those are collectively very helpful to make the beginning easier for me. That's what I want to share. Maybe my colleagues or audience can chime in if you want.
That was a very thorough response. Thank you both. Yeah, so just briefly to touch on the Intro to Grossing course that was introduced in the fall of last year for the Mayo Clinic trainees. It's a full month dedicated, and it's pretty much as you can do every day to get as much exposure as you can. And another good thing is that you get exposed to multiple different approaches based on which PA you're working with and which consultant or attending is on that day. You get a lot of input. You get to pick and choose which things resonate with you the most. So in the interest of time, we'll move on to the next question. This one has to do with didactics. So structured learning and didactic sessions are important components of training, and the composition and methods of delivery of these sessions can vary widely. What does didactic learning look like at your program? Think about the style of these sessions, the timing, the interactiveness, and whether they're virtual or in person. And can you think of any ways in which these sessions can be improved, and whether there are any gaps in your curriculum or individual learning that could be addressed to aid in your preparation for board exams, fellowship, and/or future practice?
I can take that one. So the way we have didactics at the University of Minnesota is every Wednesday morning from 8 a.m. to 11 a.m. Or 9 a.m. to 11 a.m. We have our blocked off protected time. We basically go through APCP lectures, and it's all virtual. I also did a survey amongst my peers and asked, not all, but most people responded, and they said that they really like the virtual, the way that we deliver our didactics is virtual. It's very convenient for people who are at the VA or at Hennepin. You can easily look up what the lecturer said online. You could screen grab what the person is sharing. So it's like really conducive to learning. And so a lot of the people who responded said they prefer the virtual platform. And they also really like having that blocked period of time versus like sprinkling an hour a day throughout the week. So you know that that block of time, you don't have to do any clinical service. You're just there to learn. So people really like that. Areas that of improvement that some of the people mentioned was that maybe having more board style preparation. The closest we get to that is maybe like the CAP PIP cases where we get to pick a question or pick a case and then rule out like what is the diagnosis and why are the other ones distractors or really good distractors. People also want to see more integration. So like, for example, during that 3-hour block, like if we had head and neck pathology, then we had head and neck molecular biology, then head and neck cytology, like having that integration would be really good in solidifying like these concepts that we learn in residency. And so, yeah, people mentioned that that was also really important to them. And also like some attendings do this where they have interactive polls where you can answer questions and having like multiple choice questions at the end of a topic is also really useful for us. But yeah, those are like some of the insights that I gained from my peers.
So at Mayo Clinic, we residents typically attend like 3 structured learning or didactics. So one is our standard like morning lectures. So it typically happened every day from 7:30 to 8:30 a.m. And then it is protected time unless you are on like autopsy, frozen section, or transfusion. But all the lectures will be recorded by the chief resident. So you can always go back and then listen to the recorded lecture again. Typically, so the chief resident will send out a schedule for the next week so that you know like what's going to happen next week. And usually Wednesday is CP lecture, and then the other days are AP lecture, and all the residents needs to attend. So this is less interactive compared to the others, but I think it's a more efficient way of delivering knowledge because usually we will cover like some big topics. Let's say we're going to talk about endometrium cancer for today. So it's a lot of things to talk. So maybe these kind of didactic lectures is an efficient way of delivering knowledge. And usually the attendings will save the question answers to the end. So this is one. The other thing that we have is every Monday from 4 to 5, we have an unknown session we call the Carney Conference. So this is an attending-led unknown conference for all the residents. So again, all the residents need to attend. And usually the chief residents will scan and prepare all the slides, be identified, and upload to the website. So the residents can preview all the cases with some clinical information. And then on that actual unknown sessions, so it's typically like 7 to 10 cases, and we can try to participate and then give out differential diagnosis. So this is one. And the last one, which is my favorite, is we call it an MBD conference, which is in memory of a previous attending and Dr. Malcolm B. Doherty and working at Mayo Clinic. So this is mainly a growth histology coloration conference. So what is happening is that it's 1 hour, and also attending will lead the conference. And usually a search path fellow or a senior resident will present all the cases. So first they will present like a growth picture without any information. So it will always start with a junior rather than to kind of guess like which organ we are looking at. And just based on the gross picture, what is the differential diagnosis? And then we move to the slide sessions, and then we see the correlations between the gross and the microscopic findings. I find it's very helpful. I don't know about other opinions, but I think because usually the gross findings are something that we usually kind of overlook. And it also tells us like when you are in the search path rotation, when you are grossing a specimen, which areas you need to pay attention to and how do you need to gross these specimens properly. So yeah, so these are mainly like the 3 sessions that we have at Mayo Clinic.
Thank you so much for giving us some more insight into your structured learning and what you appreciate about it and where you see growth. Yes, Dr. Albaz.
We're actually doing like face-to-face. I do believe that doing it via Zoom and 3 hours block after the first hour and a half, I don't think actually everyone will have the capacity to focus. And even as a presenter, if I'm giving a lecture to the PC in front of me, I don't know actually what are if the people are bored, if I should change it. But at the end, I'm going to be thank you for that next one. So I do believe actually having it spaced, even if the residents they prefer having it on Zoom, I'm sorry, but I think actually having it in person, I need to see the person I'm giving the lecture to. I mean, I the only thing I did via Zoom was my job policy, but that's if we have planned. But apart from this, I always do it in person. You know, I mean, and in him we do it actually. We're not part of the Wednesday thing. We have actually our own lectures. We give to the next come to us, and it's always in person. I'm totally against actually advocating Zoom because, like I said, like I don't know actually the person in front of me is listening to me or not, or is she? And I'm not saying that I'm not listening. So that's my intake.
For the University of Minnesota team, going off of Dr. Albaz's question, I'm wondering if you have any thoughts about whether or not trainees have any interest in moving some of the virtual sessions to in-person or more of a hybrid option. Has that been considered or discussed?
Yeah, so actually in the past year, several of our attendings have been taking the initiative to give their lectures in person and request that we be there in person for those. And those tend to be more interactive sessions. And I suspect that we are kind of moving more in that direction. And I would say that we as trainees are open to it. I mean, we will take the education how we can.
Yeah, so for at Mayo Clinic, so I think most of the didactic sessions are now in person. Although we always have a Zoom option, so just in case people who are working in other places can also have access to the lectures. But I think also our program directors really encourage us to attend in person because it's usually more interactive and you are more focused if you are physically present in the classroom. So.
Having virtual sessions is more beneficial for residents who are posted in the VA and Hennepin Center, so they can also have good accessibility, even though they are not in the Mayo building. So that's one advantage.
Yeah, based on some of the feedback that I've received over the years from our trainees at the University of Minnesota seems to align with what the Mayo program has done in the sense that if trainees are on site, it would be ideal, perhaps more beneficial to have more in-person sessions and then still have the option for hybrid, especially for accessibility for trainees who are rotating at other sites or who may have other obligations come up. All right. In the interest of time, we'll move on to our next question here. So this was focused a little bit more on AP training for grossing and frozen section exposure. And so we just want to know a little bit more about how grossing is structured in your programs, as well as how exposure to frozen sections is structured. And do you feel that you get enough training, too little training, or just the right amount? Especially when considering balancing your grossing time and frozen section exposure to reviewing slides and double scoping with attendings.
I can take that one. So the way grossing is structured at the university is we do grossing 8 hours in a week. We have 1 4-hour grossing day and then 2 2-hour grossing days. And then within that week, you have 1 frozen day where you're paged throughout the day from 8 a.m. to 5 p.m. And so in the survey that I mentioned earlier, a lot of the residents really love how grossing is taught here. We have amazing pathologist assistants who will hold your hand because where I went to medical school, no one taught me how to gross. So I was like shell shocked. And I was like, I don't know what to do. I don't know how to dictate. I just know how to type. So yeah, it's one of the strengths of our programs. When I was a PGY1, I felt like the 8 hours was not enough, but for some people, it was enough. Because we also have to look at the cases under the microscope and see how we can improve our dictation or how we can go back and handle the specimen differently. So I see why it's important to balance, grossing time versus microscopy. And also I've realized like throughout the years that I can gross more things in 4 hours as a more senior resident than I was when I was junior. So I think, yeah, it just depends on the resident. It might take you longer time to grow something when you're a more junior resident. I was speaking with our head pathologist assistant, Drew, and I was just talking about how do we assess competency in grossing, because once you're a 4th year and doing surgical pathology rotations, you don't have to gross anymore. Your focus is microscopy, but there's like some residents who have seen 5 Whipples in their GI rotation and who have grossed 5 Whipples, and there's some that have grossed no Whipples. And so how can we assess residents like in a standardized fashion, like saying, okay, if you are a 4th year and you only saw 3 Whipples, you are going to go back and do the 5th one, and then you're going to be qualified. So those are some areas I think that we can start thinking about, because if you end up practicing in rural Minnesota, there's probably 1 PA, and if that PA is sick, you're the one grossing. And so I think, yeah, there's a lot of onus on you in figuring out like where are your weaknesses and figuring out like, okay, I've only seen 1 laryngectomy. I should prioritize seeing another laryngectomy or maybe 5, hopefully. I don't know. Another thing that we proposed or a resident proposed was that maybe we can have a grossing month like at Mayo. I don't know what that would look like, but like things that I thought of was like, maybe we could have that person gross all the complex specimens, but just for 3 days, and then do microscopy for 1 day. And that also that resident is responsible for frozens during those 3 days, so that you can like be responsible for a lot of things and be prepared, but it'd only be like a senior rotation, not like for juniors. So yeah, it'd be nice to hear like how you guys do the day-to-day grossing for a whole month.
I can kind of expand on that. So, I mean, at Mayo, it's a very unique setting in terms of like our grossing as well as our frozen section lab, because we last week we actually celebrated our 120 years of frozen section lab. So it's a very different, well-structured setup, which is as residents, we are involved in core rotation as well as in frozen section rotations, which are structured differently. In core, let's say if you are on a GU or a GI rotation, then you will have like for an entire month, you will attend like 4 weeks of grossing in the grossing lab. But when it gets more in depth is when you are actually on the frozen section rotation, and the case volume, the complexity, and of course the adrenaline and in our frozen lab is very different than what other places have. Briefly, I can touch on like our microtome technology, in which there is 1 minute of freezing, cutting, and staining the slides, and there is live intraoperative consultation. that we are giving to the surgeons, and then the surgery is being guided from that direction. So I think it's a very different experience as to what the outside world does, but in itself, it's very unique from the standpoint that when you go to your core rotations, you kind of have like a sprinkle of, you get like a primer of grossing. And before that core rotations, as James and previously Sean mentioned, that the intro to grossing, it sets the stage. And that is something new, which is for our newer residents has started. But otherwise, the core rotations and then the frozen section rotation, it just gives you, it closes the loop in that sense. In our frozen section, we get overall 6 rotations, and the final rotation is actually a fellow month in which you are expected to act as a fellow in that capacity. So it's that graduated responsibility level. Additionally, like during frozen, there are with your level of rotation, like if you are on frozen section 1 or 2, there is increase in the microscope time, which we kind of call as hot seat, in which you sit with the consultant and you actually call out the specimen to the OR, which is a very unique experience in itself. And overall, with the advancement in your rotations, the number of hours that you give in to the microscopy is increased. And additionally, like there are 2 days of grossing and 2 days of sign out. So what specimen that I would gross on my grossing day, I would be able to call it out on frozen and then actually look at the slides during the sign out day, which is very, I think it's a great experience to kind of have that gross histology correlation. So overall, I think it's a great experience to, hone into the grossing skill as well as microscopy. I think there's a question in the audience.
I just want to add what you said in terms of going and like OR, like when I trained, it was a very unique experience too, because we would actually go to the ORs and pick the specimens and then walk back and then actually do the frozen and go back to the OR and then call and say that this is what it's positive or negative. And I think it makes a huge impact, especially it makes you feel like you're part of a team and you're very connected to the surgeons and everybody know you, and it's like a team, you're working for the patient. So I think that's something that is very unique to the grossing part. Like, if it is implemented everywhere else, it would be really great for the residents. And then another comment about the competency that you said, what we would do at our program was we would have a checklist the VAs would have, and at the end of your first year or your second year, you're supposed to look at so many pupils or so many prostates, and that kind of gives you like competency or more confidence at say that you have seen the specimen. So that is something that I wanted to add as comments to what you guys did.
That's awesome. Like, I think the relations that we have developed over the years with the surgeons is phenomenal. So that's a very unique experience to have and be able to give that live consultation.
Probably about 30 years ago, we developed a combined conference in informatics between the University of Minnesota and Mayo Clinic. And that was very successful. Even though we didn't have Zoom, we had to develop some kind of a phone hookup back then. That was before the modern day of informatics. The question I'd like to ask the residents is, do you think we should try to begin to develop combined conferences between the University of Minnesota and Mayo Clinic?
I mean, I think collaboration is certainly, which is among our core values. So for sure, this is like an educational outreach. So whenever there is collaboration, I would say like we always see like, and there are other places, if you see like Florida Society of Pathologists, there are frequent instances in which they have arranged inter-residency program jeopardies. So there are multiple avenues in which way the residents from different residencies can collaborate, and it will expand our horizons to learn from each other. So that's a great point. Yeah.
Is this working now? Okay. Piggybacking off of that, I think it would be very beneficial for us to interact with each other and see the different modalities of learning that we each have and share sort of the best of each and, you know, have sort of an exchange of what is the best way to learn.
And just as a preview, one of the efforts that Dr. Fleming and I have been working with in conjunction with Dr. Chin and Dr. Chilla at the MSP is to try and set up more of a trainee forum where we'd have more opportunities to share things like case discussions and unknown sessions and things like that among the trainees. So we could have more opportunities to at least work with each other, if not collaborate and learn together. And then Dr. Ramos has a question.
Hi, guys. So I have a question about communication with, surgeons, clinicians, during process and grossing. So who do you, and it's all of you, right? Like when there is a question about grossing, who make the call, you or the PAs? And when there is a frozen result, are you really involved in giving the diagnosis? If the surgeon or someone else have a question, are you able to have an answer, or is usually whoever is in the back, the pathologist who answered this? And thank you.
Well, I'll just give my perspective on the frozen aspect of your question. So in our center, we usually go, when we get the page, we look at the specimen, we gross the specimen, we collect the preliminary clinical information, and the slide is usually ready when the attending comes. Sometimes we get, most of the time we get the time to see the slide and have our own opinion. And the attending comes and they ask our opinion on the slide, okay? And then we do get opportunity to call the OT and deliver the report. There are other times where the attending themselves do that. I think that goes a long way in building confidence in interpreting frozens. With respect to the cross question.
So Dr. Ramos, were you asking about when it comes to questions about our grossing, are we able to answer the questions to the clinical team that is like sending the specimen?
Let's say there is a specimen, you don't know the orientation is correct. You don't know if that's a margin or true or not a true margin. Are you able to call the surgeon and ask these questions, or whoever was involved in the surgery, or is the PA who takes care of this kind of thing?
So usually like when we're on frozen sections, we are able to ask the surgeon, because most surgeons, well, a couple of them, not most, will walk in the specimen and orient it for us. And they'll say, especially like for the head and neck cases that are very complex and have multiple sides to it, they'll orient it. And if we don't understand, we can easily ask them, looks more like anterior. Can I call this anterior? Because you're calling it something else. And so, yeah, we usually do have that discussion when we're on frozens and when the tissue is fresh. But when the tissue is fixed and we're on our grossing day, it's more, I think, like if there's any questions about orientation, we usually ask the PAs because maybe we didn't get that tissue fresh and we don't know about the orientation. And there is a PA that received that specimen fresh. And if there was any questions about the orientation, usually whoever's on frozen or whoever PA did this case will give us that information when we're grossing. So usually, yeah, it depends whether you're on frozens or whether it's your grossing day and you're not on frozens and don't have the ability to ask that question when the tissue is right in front of you fresh.
So a quick question. Do you feel like when you're working with the gross specimens and when you're working with the frozen sections, do you have sufficient autonomy, especially as you become more senior in your training, with respect to handling those specimens and reporting the results to the clinical teams?
So yeah, so in terms of autonomy, usually it's at the beginning, we just mentioned about the introduction to grossing months. So you will always be paired with a PA. So basically the PA will walk you through for all the specimens that you encounter. But once you go to like your co-rotation grossing months or your frozen section months, you have this kind of graduated responsibility. So you are less and less reliable on a PA. So maybe the PA just give you some very general instructions, and then you can tell them what you're gonna do, and then you just grow the specimens, and then you can directly work the specimens to the consultant, the attendings, and then you finish the grossing. And if they have any questions or you have any questions, you are always being able to find a PA to help you. So I think that's what we did.
Yeah, I agree. I think we have a really great rapport and a really great team of PAs that we work with. And I think they're very good about assessing sort of where each individual is at in their comfort level and sort of tailoring their level of support to our needs.
And one more point to like how our frozen works, like since it's like in the same space. So I would say the frozen at frozen we have a lot of surgeons who would walk in with the specimen. So many a times, although like we call it out in the overhead, the report, but if they have additional like questions that they want clarification for, they would just walk into the lab and we can just have like a right away discussion. The pathologist is there, the resident or the fellow, whoever have called it out, they are there. But throughout like the way the rotation is structured, the calling the surgeon is mainly either a fellow is calling it or the resident who is taking the hot seat is calling it. And the pathologist is sitting right next to you. So that gives you that autonomy that you are actually calling, but then you have oversight right next to you. So the pathologist can also like add in if there's some additional questions that they have.
All right, thank you all. That was a good discussion about grossing and segueing into somewhat graduated responsibility topic. The next question has to do with multidisciplinary conference participation. So participation in intra and interdepartmental conferences are an integral part of training and of pathology practice in general. As a trainee, how frequently are you involved in multidisciplinary or consensus case conferences, and do you find these a valuable component of your training? Do you have sufficient opportunities to present cases at these conferences, and do you feel like your experiences adequately prepare you to present cases to both clinical and pathologist colleagues in the future?
I can take that. So I believe that our program is very generous with respect to consensus. We have consensus every alternate day on Monday, Wednesday, and Friday. It usually starts off with pathologists from the other centers presenting any difficult or complex cases that they may have in their routine sign out. These are usually atypical cases, which most cases don't go by the textbook. Okay, and these are the cases I believe need additional attention and training, and we see them sometimes present over Zoom or present in person, and everybody gives their own input, and even all the fellows and residents are free to contribute to the case pertaining to whatever controversy is in that case that is making it complicated. And we also sometimes we present interesting cases that we have come in our sign out or teaching cases. The attending, sometimes they concur and sometimes they do not. In that case, they clearly explain what was the better approach to the case, that it would have resulted in a better presentation and correct diagnosis. I think all this go a long way in developing one's diagnostic skills pertaining to difficult cases that come across in practice.
I was going to add about like our participation in tumor boards. Like for example, there's this conference that we do is called RadPath on breast service, where the radiology resident will basically have a list of cases, all the breast biopsies for the week, and basically the radiologist resident, which is really nice because you kind of feel like, okay, we're in this together. They present the radiology findings, and then you quickly pull up your slide, show the relevant findings, and then they say, oh, it's concordant or not concordant, or most of the time it's concordant. And so that's like one example. Even as a PGY1, I was terrified to do this, but I was pushed to do so, and I really appreciated it because our job is to communicate our diagnoses and learning how to like make things make sense for our other colleagues because we're so siloed. Actually, yeah, I think because we're so specialized that people don't really know what we do. So like getting better at communicating and explaining to people like, why did we give this grade or why did we give this diagnosis? Also, other specialties have different tumor boards as well, where we could just pick one case that's really complex and show the FISH studies and show the IHC and show the H&E stain slides. So yeah, we have really good, robust participation in tumor boards. And I think, yeah, you get more and more responsibility as you progress through the years. Like, so Ram over here does a lot more presentations as a senior versus me, who is like more junior.
Yeah, Aisha was emphasizing that the program follows clearly a graduate responsibility when it comes to these things. The attending makes sure that you're comfortable presenting the case in tumor board. And there are times where I have been allowed to answer the clinician's questions pertaining to that case. I think that's very generous of the attendings, and that has helped me improve my confidence. Thank you.
I can share some of my experience. So tumor board presentation is not required in most of the subspecialties in Mayo Clinic residency training, but we are encouraged to participate in tumor board. Some subspecialties I had experience like medical renal. We had a interactive, like multidiscipline team with the clinical team, and I presented a case there, like show the clinical team what is our thought and what is their thought. So we exchange ideas. And another subspecialty is neuropath. I think E can probably comment more on it. We have radiologists, clinical like neurosurgeons, and pathologists. They have like every Friday morning tumor board. That one for resident is required for participation, but we are not required for presentation. It's the neuro fellow will present, right? And for my personal experience and my feeling, I see Dr. Chen here in the audience. I would love to have more exposure to have the opportunity to participate in tumor board. For example, presentation opportunities, maybe we can incorporate more of those opportunities in our core training months. I think that would be beneficial. Yeah, but feel free to share your experience.
Yeah, I just completely agree. I think at Mayo Clinic, I think the residents probably should have more opportunities to present in the tumor board. For example, like the neuro pathology, we have a conference every Friday morning, and then it's usually presented by the neuropath fellows. We usually discuss like 4 cases, but I feel like I learn a lot by just discussing the cases with like not only the neuropathologists, but also like the oncologists, the neurosurgeons, the radiologists. So they share their perspectives and we share our perspectives. For example, we just presented like a case last week about meningioma, and then they asked questions about grading because neuropath is a very rapidly changing word. And then we change a lot of like criteria like in each editions of WHO. And also there's a lot of advances in the neurosurgery side and neuro-oncology side. So it's very beneficial if we can learn from each other and then present cases and share our opinions with each other. So.
Thank you so much for sharing your experiences. Really appreciate it. I know we're approaching time, so I'd like to get in at least one additional question that is fairly on theme for the talks today. And that regards digital pathology and how it's incorporated into your training. And so especially as digital pathology and AI becomes more and more commonplace in pathology and pathologist workflows, just wanted to ask you about your exposure to digital pathology and AI, if there are structured courses, either required or elective at your institution, and whether or not you think that your exposure is sufficient to allow you to be prepared to work with these technologies as an independent practicing pathologist, or to potentially bring new technologies and things on board at your future practice.
Yeah, so we have a digital pathology elective, and then we also have an informatics elective. We don't have a dedicated AI elective. I don't know if that would be possible to develop in the future or to merge a little bit more with digital pathology. I think it's a really interesting topic in that it is so new. It is so emergent right now, and you know, I think it's really important to emphasize the use of AI as a tool and to train us how to use it as a tool, and to be very cautious in, you know, becoming over reliant on it. And I think it'll be, it'll end up being in much the same way that, you know, when you were younger and you were learning how to look up a question on the internet. I think in the earlier days, it was maybe you had to be more aware of what you were asking and how you were asking it and asking the right questions. And so I would like to see, you know, more integration. And I think it's so complex and it can't be its own subspecialty. It's going to have to be integrated into every subspecialty independently. And I think there are a lot of logistic things that we need to work out too. So perhaps we could be involved in helping to develop that curriculum.
Thank you, Marisa. So I just wanted to give you a point. Recently, we had the department has been we have started the Halo software. Okay, it has 3 components: Halo AI, Halo Link, and Halo AP. Okay, we had a very detailed training session for the same, and we even have recorded lectures we can access, which teaches how to use the software. I have been collaborating with Dr. Morgan and Dr. Giubilino for assessment of tumor infiltrating lymphocytes in melanoma, and the lecture is very clear. It takes you through how to use the software and how to train the software into an algorithm so that it can make the interpretations as per your wishes. Okay. We have different modules. We have the spatial recognition module. We have the close proximity module. We have IHC analysis module. We have about 5 different modules. I have been given full access to those. I think I have learned a lot, and we are really getting there in training the software in interpretation of these different indices used in everyday sign-outs. It's in a very early stage. We will get there, of course.
So at Mayo, we are like totally digitized. So in terms of like saying that if we have a formal training or education about it, I think as part of the training, it becomes second nature because everything is digital. We do have access to glass slides, but if we talk about how the structure of digital pathology feels like at Mayo, it in its true sense is like total replacement of the glass slides and paper reports with digital images and scan reports. So it has put us in that position of operational efficiency in the diagnostic workflow so that we don't have to wait for glass slides to kind of look at the cases in particular. So in general, I think we don't have like structured training ongoing. It's mainly the day-to-day work that we are we just work in that fashion. Although like we are encouraged and we still try to keep looking at the glass slides because it's not going away anytime soon. But overall, the digital space, there had been like a lot of energy to bring more innovation with the adoption of the digital slides. It has given us digital tools. As like in glass slides, if you have to make any annotations, you would use markers or so, but in through our Sectra platform, now everybody does a digital annotation. And the beauty of it is that you can actually see who has made the annotation. If I'm measuring a tumor or like a distance to a surgical margin, I would have like an annotation made in Sectra and the consultants can actually look at it. Also, the platform gives that advantage is that there can be multiple users signed into the same platform, and we can have conferences in which even if people consultants are in their office or other place, we can like trace and track like who is in the case and kind of where they're pointing to. So it's a totally different experience in itself, but other than that, with incorporation of AI with the having the utility of the digital images, we have a sandbox through Iphoria, which is a cloud-based platform, and that's a lot of projects are ongoing. We have a lot of consultants who are actively working, including one of my mentors, Dr. Roger Morera. We have developed like AI algorithms for steatosis, eosinophilic esophagitis, hepatocellular carcinoma. Those efforts are in research and making sure that these algorithms are dictated and fed by pathologists so that we can train these models and eventually bring them to our practice. So from the leadership standpoint, there is a research and innovation. Every Tuesday, there's a meeting in which external presenters, they come to just keep update and abreast with whatever latest is coming. I know there are talks about additional digital platforms, including TechSite and other institutes that have experience in the digital imaging, just to kind of like expand the market and see what other places are doing. So yeah, that's kind of.
So do you use these algorithms everyday sign-on?
Not yet. So it is still a research. That algorithm has been developed. It has been like tested through, but it has not like come to the practice yet. But like we've like spent hours in developing that and validating it, because a lot of it goes into development, but then applying it and making it applicable universally, it's another level of scrutiny and validation before we actually, start signing out cases with that.
Sorry. Oh, sorry, Dr. Wild. I think we're coming up close on time, so I just want to take a moment to, again, thank all of our panelists for being here today. Before we close out the session, are there any last minute questions from our audience members? Either. Yes.
We do the whole training at Mayo, but we do have options. Like if you want to go to Mayo Clinic, Arizona, I know you can arrange like external rotation. Was that your question?
Yeah.
Yeah.
Because, for example, if you rotate in a community practice, hospital, you gain an entirely different perspective.
Exactly.
And quite a few of you, after you graduate, you will end up actually in a community practice, right?
Yeah.
So you want to experience that before you actually start.
That's a great point. And that's, I think, one of the things that our mentors always emphasize. And at Mayo, regardless of the fact that we have like 99% digital practice with the exception of hempath and cytology, but we have access to glass slides all the time. So when I was a first year and I was like new in the space and learning, I wanted to make sure that I get the feel of the microscope and glass slides and all. But slowly and surely, like we realized that we can do both. And when we go to our frozen section labs, the initial slides, the Tolidine blue slides, they're all glass slides. So we get that exposure of looking at glass slides from there as well. And eventually they do get scanned in. So we get to have the feel of both, like looking at that slide under the microscope as well as the sector as well. So.
And for the University of Minnesota team, how do you feel about your exposure to other practice settings? Do you feel like you get some good experience rotating in like community and private practice or academic, or is everything academic?
Yeah, we actually have quite a few rotations that we go through at other institutions. We spend 3 months in first year at the VA Medical Center here in Minneapolis, and that gives us, kind of an entirely different perspective on how practices look in sort of different settings. And so with that more community-based model, it's interesting to be able to see, what are the benefits of each model. And, as someone mentioned, you mentioned, Dr. Richilla, a lot of us will end up practicing in the community. And so I think it's extremely valuable experience to be able to be exposed to that early in training. We also rotate through Abbott and HCMC. I haven't done those yet, so I can't speak to that. Okay.
As someone who has completed their rotations as a resident, I can say that I think it is really beneficial to be able to have dedicated time to rotate through on required rotations in various practice models, just to help you get an idea about your professional identity as it's forming and to try and figure out what setting might be most ideal for you for future practice. So that is something that I do appreciate about our training, particularly at the U, is that we do get those experiences.
I would like to add one quick thing on this topic about doing rotations at different sites. I think that would be a tremendous opportunity. There is a way to do external rotations within Mayo Clinic health systems. So for example, if somebody's interested in seeing community setting or working in that facility or potentially looking to find a job opportunity, they can go, for example, like Mayo Clinic Health System, Eau Claire. I know that one of the former residents to go on to a fellow did something like that, and they spoke very highly of something like that. And then I did want to mention back to the topic of digital pathology and AI, because that is a focal point of today's discussion. From the trainee perspective, I think that we become well-versed as end users, maneuvering through and learning all the tips and tricks to be successful and efficient in that regard. But it takes a lot of introspection to say, is this learning the technical execution of this? How much of this do I really know? And would I be able to take that infrastructure, that scalability, and bring that somewhere else? Because that's something that was mentioned earlier, not only about DigPath and AI, but also informatics. It's like a very valuable realm of thought to some other people. Even mentors I've had have said that if you know how to use the technology, that might be good enough if that's where you want to draw the line. So I just wanted to mention that. I'm not a panelist, but I'll go back.
And I totally agree with James. And to that point, like as a pathologist, I think it's time to think about, we have AI and we have all this technology, but in our field, where do we need that AI? Like that is why, like when we start talking about the integration of AI, the first thing, and you will talk about it, the next question you hear is that, is it going to replace us? So when we are the ones thinking about where do we need to use AI, so thinking it loud, anywhere in our diagnostic workflow where there is bottlenecks that makes us inefficient or is like cumbersome work. So one example is like the eosinophilic esophagitis algorithm, because that counting, it just takes time and we can use machine to do it for us. So that is where we should integrate AI and take lead in training these algorithms so that we can incorporate in our practice. In no way it's going to replace me or my job or any of the pathologists here in this room. So this is something to think about, that where do we actually need these? And then probably we don't need it to make the diagnosis. We need it where probably I don't want to count mitosis for meningioma and spend my entire night doing that case. So some of those things which are really dreadful, if you are a new resident rotating through neuropath, you might have felt really alone that time doing it. So those are the places where we need to incorporate AI and kind of make use of it.
Yeah, I couldn't agree more. Even the people who are involved with developing these softwares, they believe that pathologists are the one who can train the software accordingly to make a diagnosis as per their desire, as per what they're looking for. Okay. Even a person who's developing the software may not be able to do that. I think the pathologist would have the best perspective and idea about how to use the software. And
Sorry,
Hello link
sorry to
videos.
interrupt. I think we're actually at time right now. So let's give our panelists a round of applause. Sorry to interrupt.
Thank you very much. I mean, it's been great, to hear from you. We'll keep this in the future. 1 hour will be actually dedicated to both sides, Mayo Group. Thank you very much for coming, and University of Minnesota Group. But we'll have different topics.